Here at a study session for the Douglas County Commission. Today, our study session is on Black maternal health, and we're really excited to have some guests with us for this important topic. As a reminder to the public, anyone listening in, either on Zoom or anyone there at the courthouse, our study sessions are for informational purposes only. We do not take public comment during our public sessions traditionally. Or we also don't vote on anything. If you do have public comment, we welcome you to join us at our 5:30 business. With that, I will turn it over to Sarah Plinsky, County Administrator, to introduce our guests and kick off this topic.
Thank you, Commissioners. Actually, I'm going to turn it over. She's going to do introductions.
Thanks, Sarah. All good. Well, I'm really excited to have our presenters here, and I think it's really great to have the information that they're going to give us, kind of just to inspire some of the work that I think and as a community as we move into the new year, and maybe we're not so focused on coronavirus, but one can hope. But I'm really honored to, I've had the pleasure of being able to work with our two presenters today, Alex Kimball Williams and Christina Gentry, on a lot of work associated with the community health plan. In the most recently with Alex, since she's joined the health department, but Christina has been engaging on this work for as long as I've been working on the health department. Christina has been a very and strong voice in the work that the health. And I continue to, as we work through the community health plan and the anti-poverty work group that I'm a co-convener with Leah Roslin of the United Way, surrounding Black maternal and child health, have come up, and I had heard from Alex and Christina that they were working on this, and there was information that they were presenting with different groups, and I thought it was important information for this group to have and the community to have, again, because I think the work that the community health plan is engaging in around this population and all the work that we're doing as a community and the impact that COVID has had on certain populations in our community, it's important. And with that, I'm going to hand it off I'm going to let Alex and Christina introduce themselves and get our conversation going.
Thank you, Jill. And thanks for having us here tonight. We are excited to present and share this information out because like you mentioned, these health disparities persist through COVID-19, and there's been a lot of really great emergent research regarding maternal and child health, especially at the intersection of being Black and or low income. And so we're really excited to talk about this tonight. Again, my name is Alex Kimball Williams. I use she, her, they, them pronouns. And I'm a Lawrence native. I work at the health department, as Jill said, as the health equity planner with Christina. And I'll hand it off to Christina.
Oh, thank you. And thank you for inviting us, commissioners. We appreciate your time. And thanks for the intro, Jill, as well. So my name is Christina Gentry. I work at the Lawrence Douglas Public Health as community liaison. And my responsibility to the information that we'll be sharing and presenting to you today is working with the MCH grant, the MCH grant, which is a grant that was given to us by KDHE about 2 years ago. And so I came in kind of on the tail end of it last year and been working full force and speed with Alex Kimball Williams and some other multi-sector partnerships, hospital, and Jen Preston working at the health department as well. So we're coming to you prepared to speak on our findings, and hopefully this will get engagement into our report and support for our report that soon will be following this presentation.
Yeah, thank you, Christina, for mentioning. We had a fantastic team with different folks as well. So definitely a huge shout out to Erica Hill, Jen Preston, Sarah Hartzick at the health department as well. So thank you for remembering that.
Absolutely.
We are just two members of that team.
Right. So you got the slides up, and yeah, thank you for that visual right there. I can see it. We've given kind of a little bit about the reason we're here and what we want to present to you. But our presentation overview consists of a couple key topics. We come prepared to provide background information or framework to our research topic on Black women's maternal health, also providing research and forms, including but not limited to focus group questions and answers that came from our participants. We will include here our goals and the design used to capture what is a narrative of Black women's pre and postnatal birthing experiences, including direct quotations from our Black mothers. Alex and I will conclude tonight's presentation with next steps that need to take place in order to create forward movement on this issue. Here's a quote here, and I would like to kind of read out loud for those who are listening at home and maybe needing to have some captions closing. I realize I may have some audio issues tonight as well, but I want to make sure that we're giving information and reading as much as we can tonight. But here is a quote, a direct definition describing health inequities. And health inequities is described as systematic differences in health outcomes. Health inequities are differences in health status or in the distribution of health resources between different population groups arising from the social conditions in which people are born, grow, live, work, and play. And this definition comes from the World Health Organization 2017.
Thanks, Christina, for kicking us off with that very important definition as it frames the rest of our work. You know, we are looking into health disparities, but specifically we're looking at the intersections of health disparities as experienced by people impacted by, marginalized gender, race, ethnicity, culture, perceived or actual class. Looking at Black maternal health work, involves several intersections, a step beyond just traditional maternal health, which usually just deals with gender and sometimes class. The key issue with the intersection of women is that they typically have the burden of establishing their competence in addition to advocating for their health and having normal interactions with their healthcare professionals. And this is exacerbated by also being Black or having low class or perceived low class. Let's see. I'm managing the share. A couple of key statistics that we wanted to pull out regarding the intersections of Black maternal and child health care is that the United States has the highest maternal mortality rate among affluent countries in the Western world. This is not necessarily new information, but it's definitely information that informed a lot of me and Christina's work. U.S. women report the highest rate of chronic illness, hold the greatest financial burden for healthcare costs, are the most likely to miss health appointments due to costs, and are the least pleased with their health care. And so when we look at the compound impacts of Black folks having chronic health conditions that persist without remedy, as Berkeley says here, Black women are more susceptible to maternal mortality because racial disparities and hypertension, among several other chronic health issues, persist without remedy. And so folks, Black families and Black infants are impacted, consistently across the board, not only in chronic conditions, but then of course, when you go into maternal care, these things come with them. So this is a little bit related to some of my academic work as well, looking into medical and case studies across history. But we wanted to pull this up because a lot of these experiences that were reported by our focus group participants, but also in the literature review that we conducted across national studies for Black maternal health, included experiences that could be categorized as medical malpractice. These things are part of what prevents and discourages people of color from accessing preventative care, and it severely impacts the care that Black mothers and families receive throughout pregnancy and after birth. At the top here, I have a kind of medical definition of medical malpractice. And then the second definition is more of a legal definition of medical malpractice. But I want to call attention to the last paragraph about the examples of what constitutes medical malpractice. That includes improper medication or dosage, premature discharge from care, poor or no follow-up care or aftercare, misreading or ignoring laboratory results, disregarding or not taking appropriate patient history, failure to diagnose or misdiagnose, failure to order proper testing, failure to recognize symptoms, and many more. These are many of these are examples of things that our focus group participants referred to, and that we also noticed in our research outside of our focus groups. Of course, it's one thing to experience medical malpractice, and it's another thing to prove it in a court of law. So oftentimes the cases of medical malpractice actually happening in our country are widely underreported because, of course, you have to have access to resources and time to pursue legal action as a result of medical malpractice. But a lot of the Black maternal health experiences, including some of the high profile ones that we'll close today's presentation with, involve very blatant medical malpractice. I also want to talk a little bit about the dose gap. Gap refers to the fact that different bodies and different people have different liver and kidney metabolisms, and so they process medications and supplements in different ways. This arises out of the fact that we often engage in opportunity sampling, often gathering white male college-age students in a lot of these clinical and trial studies. Studies disproportionately include white folks and men. Only about 1% of most clinical trials involve Latinx folks, only about 5% involve Black folks, and only 33% involve women. And so that's really huge disparity there in terms of the research that's happening, especially considering that many health issues are race specific in terms of their prevalence and or incidence. Only 5% of the genetic traits linked to asthma, for example, in white Americans apply to Black Americans. So that means that we are giving Black Americans asthma medication, for example, which is a huge cause of death in Black children. We're giving them asthma medication which does not correlate with their own body's pathology of this disease. And so we are misdosing, which again, going back to medical malpractice, we are misdosing a huge part of our population. We also have the issue of what minority health needs that we even focus on. Only 2% of studies involve what they call minority health needs. And this disparity exists even after the NIH passed some legislation to increase diversity in their clinical studies. A lot of this, creates a missed scientific opportunity to fully understand diseases and disorders, as well as infectious strains and chronic conditions when we focus only on white pathology and privileged regions such as the global north. If we are not fully understanding a disease or condition, or we are limiting ourselves to white pathology, we are not fully understanding that condition. We often see this in terms of HIV/AIDS. We only focus on certain strains of that do not affect people on the African continent. But we're also seeing some of this play out when we're in regards to COVID-19. But going back to explain a little bit more about metabolism and the differences there, as I mentioned before, medication differs in efficacy, severity of side effects, and fatality based on metabolism. The liver metabolism of people of European descent is generally faster than for people of color, which includes Black, Indigenous, Latinx, Asian, and more. I know that at least at KU, they made us take a course to understand that people of East Asian descent have lower alcohol thresholds, and that's tied to liver metabolism. So that's just kind of a popular kind of science reference to that I think a few of us already know about. But I think the main thing about the liver metabolism is that liver enzymes can raise and cause damage with some medications, particularly medications that are long-term or have cumulative effects. And then the last thing to talk about, I hope I have everybody with me here. If there's any questions, feel free to interrupt. The last thing that me and Christina definitely took a look at was the differences in pain management. Black folks are less likely than white folks to receive pain medication, and when they do, they receive less. There's a lot of stereotyping about Black folks being drug seeking, and this impacts Black maternal care because, we are not administering medications the same way, and we have assumptions about whether someone can afford the medication or the intervention, and also if they are drug seeking or not. I am super impressed with the University of Virginia. They put out some really great research about these pain management differentials, and they did a survey with their medical professionals and students at the university, and they found that the majority of them believed that Black people had fewer nerve endings, thicker skin, blood that coagulates faster, and quicker recovery times after injuries or trauma. And so if this is what medical professionals and students are believing, we can only imagine what the general population may believe. These things impact maternal health care because we don't believe that that Black patients feel pain in the same way, or that they need as much medication to address their pain. We don't understand what Black pain looks like, and we don't validate Black pain. We also believe, in the later end of this, when it comes to blood coagulating faster and quicker recovery times after injuries or trauma, we're seeing Black patients get called back less for aftercare. And there's a significant risk in the first year after birth, pregnancy and birth complications. Again, as it relates to Black maternal and child health care, we have increased fatality in situations where interventions are chosen and medications administered on the basis of patient pain, particularly the provider's ability to perceive it the same way as they perceive the pain of white patients. This implicates not only in maternal death rates, but also infant mortality rates, cancer survival rates. There was really great research that came out in August showing that when a physician is the same, I guess I don't want to misquote their research. So their research was focused on Black physicians. They showed that Black physicians caring for Black infants, that Black infants had fewer or a reduced chance of fatality, whereas Black infants that were in the care of white physicians had 2 to 3 times increased fatality. And so racial concordance plays a role as well, not only for maternal care, but also for infant care. The research did show that there was no difference for maternal death rates based on the physician's racial concordance, but there was definitely correlation for infant mortality. And then some of the key equity takeaways, I know we've covered a lot, and those are just summaries of extensive research into each of those topics. But something that we wanted to uplift was that Black and Indigenous people of color often do not receive the same access to medical care, medicine, referrals, follow-up care, generally the medical advancements that our society researches and implements. And this comes as a great irony, because oftentimes Black and brown bodies are used when convenient, such as the origin of gynecological care, but they're not prioritized when they're needed later, hundreds of years later, when we have these Black and brown health disparities. The issue with an equality approach to medicine is that it defaults to, and that's what we see in how we handle pain medicines, how we handle dosing in terms of the liver metabolism rate, and other things that we've talked about so far. All right, so I'm going to hand it off to Christina.
Well, thank you, Alex. And to be sure, this is a lot of information tonight, and we'll be more than welcome to accept your questions at the end of our presentation. But moving on, our grant research asks this overarching question right here, and that is, what are the pre and postnatal experiences of Black women in Douglas County, Kansas? It's with that we came to dissect it further by using authentic inquiry methods and that concept to understand how we can ask this question in many different forms. Next slide will show an example of the focus group questions. There they are. So these questions numbered 1 through 6 here are what we ask our focus group participants. And we asked the mothers who were in the room all of these questions. And we also did an extensive outreach to give a couple of lenses to these questions. We wanted to make sure that, one, we weren't asking questions that were polarizing or would make a person feel defensive rather than to be open and have a conversation. These were designed to create an environment of welcoming, personal, and often painful experiences of Black women who self-identified as Black and who have had birthing experiences within the last 5 to 6 years. So the information we collected was recent, meaning that these women currently live in Douglas County, and also that their children are under the age of 6. So all of the information that you're going to hear tonight comes from these questions as the answer to these questions and from the women who have experienced this inequity. So they're designed to ensure that we weren't placing onus on the women to prove their pain also. So we didn't want to create a defensive response to these questions. And I would like to talk about the last question here. For time's sake, I won't go through one but number 6 was really important to us to understand, because it reads here, what factors do you believe or think contribute towards poor infant health, such as low birth weight or infant mortality? And this question posed as a little bit of a, I want to say, a problem for us in going forward. It made the participant, understand that there was probably a perspective that was overarching to the data that was collected. So it asked the person, what do you think are the experiences, or why do you think this happens? And why do you think this is an inequity? So that's just a little bit of context, because otherwise the questions were absolutely asking a woman about their personal experiences, but that last question was asking about an overarching theme of Black women's health and low birth weight of infants and Black infant mortality specifically.
Yes, thank you, Christina, for giving that context. We put a lot of work into these questions, and other folks from the Equity Coalition that weighed in on them. So just going quickly over our timeline, we definitely put a lot of research and development in terms of our literature review and determining these focus group questions, as well as our overarching research questions, as well as our data sources and methods. We then engaged in focus groups. We were originally going to have 4, but COVID happened and we only got a chance to have 2. But in those 2 focus groups, the narratives that we've been analyzing. From there, we transcribed and coded for themes the narratives. And then, currently right now we are working on completing a report. We are connecting and applying for grants and hoping to continue our work with LMH Health, the Health Department, Success by 6, Uzazi Village, Emily Taylor Center at KU, and so forth, so that we can enact the solutions and specifically the interventions that our focus group participants mentioned.
Oh, that's me. Okay, great. Let me just zoom in. I'm using my phone. So our process is as such here. Racial concordance was used. Racial concordance is and it refers to having a shared identity between the provider and those receiving care. And in our case, it was Black women interviewing or facilitating conversations and interviews with Black women regarding their birth experience. The method that we used was participatory action research and thematic narrative analyses. And our framework was an anti-racist framework. It was multidimensional and intersectional. And again, these are all some heavy words, definitely require a little bit of going into it and more conversations. And if you had any conversations or any questions about this method, our framework, or racial concordance as it is, we'd love to delve in with those with you after our presentation.
Yeah, we would love to delve into those. And then also the upcoming report is extensive. And so if you would like to read more, we have a whole methods section that talks about how we enacted action research principles.
And Alex, I know that this slide was designed for me to speak to it a little bit, but I feel like maybe you can expand upon it a little bit more than I can at this point. I got my notes mixed up, and I definitely don't want to take away from the theme that you have presented on this slide right here. So if you wouldn't mind speaking a little bit to the shift in local research narrative and empower.
Definitely. So we had 2 main goals. Thank you, Christina, for speaking to all of our central research questions and our frameworks and our methods. That's so important. We had 2 main goals in our research. We wanted to shift the local and research narrative from one that put the responsibility on Black as being the cause and the source of the disparities, and one that focused on racial bias, historical bias, and things that have happened throughout history, as well as the compound inequities that we talked about, such as hypertension leading to low birth weight. And so we wanted to make sure that we were, because a lot of the research about maternal care, so if only they had access to the care, or they had more income or more education, they would be doing so much better. But there's actually other ways of thinking about it and framing it, and other places where responsibility might be placed. And so we made sure that throughout all of our questioning, our focus group conversations, and our research was one that phrased things in an empowering way and not a disempowering way. We also wanted to empower Black and Brown voices within the community and public health domains and improve healthcare experiences if we could. And that is again tied to our action research principles.
Here we are. So right here, what we have is a direct quotation coming from one of the participants. And I feel moved to read out loud. For sake of time, I would like to maybe have a couple of minutes to read these words that came from our Black women as they spoke them. So I'll just read a little bit and then I'll give a little bit of context for each. This Black woman expressed that I had known my doctor for a while. When I previously lived in Lawrence, he was one of my gynecologists. But when I came back to him pregnant, I felt judgment. And it was almost a joke, but it wasn't a joke. And he didn't say anything after that. And it was, I know you're judging me. He didn't say anything and we were disconnected. And what you read here is an example of provider care bias. Often the fact is that individuals and communities interacting with healthcare systems are subject to disparate treatment at the hands of clinicians. All participants that we reviewed noted prenatal stress can range from severe to moderate to mild. And the majority of human studies show that mild, moderate, and severe stress can negatively influence pregnancy outcomes and development, both physiologically and behaviorally for the infant. This is a quote here I won't read out loud, but I will give a little bit of context and background. Because mothers and all participants that we had interviewed noted feeling that there was a lack of resources available to them during their pregnancy. So I'll give you a little bit of time to read that. We'll go on to the next. That's okay. I didn't know if everyone was a slow or a quick read, but I wanted to make sure those words were read and understood. Okay, I think we can move on to the next slide, Alex. Thanks. Mothers said there was a lack of societal and community support, or this may be an example also of classism or perceived other as classism. This mother said, I felt like there was no one there to ask if we're really struggling. I feel like the majority of people who went to women's health care were like upper class because there was never any help or anything or with anything. This, like I was pretty upfront and had lots of talks with my healthcare provider. I feel like there wasn't shared knowledge that was helpful for me. Black women, Black mothers noted that they must advocate on their own behalf, and there was knowledge that would have been useful but was not being shared. This participant in particular was a Black mother who was vocal and proactive with her healthcare provider.
This is another quotation that was from our focus groups. They said that there were no people of color that worked there, and they were referring to their healthcare provider that they were going to for prenatal health appointments. And so this was a situation where they felt that there was that looked like them, or that they could really talk to, or could really understand their own situation. Another thing that came up was, obviously you may request a doctor who looks like you or a nurse who looks like you. You may prefer that, but because they were going somewhere that had nobody like them, that wasn't even a question that they could ask. Another couple of quotations was, when I was in labor, when I knew redacted name was coming out, they didn't believe me. They kept coming in and forcing me to put her in the bassinet. I didn't get a lot of skin-to-skin time with her that I wanted to. In Texas, where I had my son, a different baby, they give you at least an hour of skin-to-skin time. Something that me and Christina did not anticipate in our focus group research was that we would have participants that had birth experiences outside of Kansas and some that also had birth experience within Kansas. And so that provided a really helpful comparison for us between different states and what they had come to expect. A lot of them indicated that the care here was in some way worse than where they had a different birth experience. And then also related to the first quote, a lot of them experienced being gaslit or being told that not to listen to their bodies in some major way.
So our main conclusions are located here. I was looking at something to also speak on, Alex, with that quote, but definitely can move on and come back. But the main conclusions to our participants' research and our data that we collected through 2019 to present were that there was a shared unwelcome feelings. Our participants felt unwelcome and stereotyped by their doctor's offices, in their doctor's offices by their doctors. The appointments felt rushed. Our participants noted that doctors and nurses were not taking the time to fully understand or to fully give answers to their questions or understand their situation or meet their specific needs. They noted there was not enough information, uninformed and coerced into doing by the medical professional or personnel. And they remember mistreatment. And I think we've given you some examples coming from the women that we interviewed to speak just to those couple of topics. I wanted to also note that it's important to note that there's an ongoing challenge for researchers in understanding the role of racial and cultural stress in augmenting the effects of the types of prenatal stress described in Black women's experiences. Increasing data suggests that racial stress is a huge contributor to the persistingly higher rates of low birth weight, infant mortality, and small gestational age infants observed in African American, Black women compared to white women. Our participants also noted that they would love to have support groups. So these are some topics that maybe some interviews were proposed in our research groups. They wanted to have improved office protocols. I think that was probably as a result of us understanding that improvements need to be made in office. There was an expressed accessible information about practices and resources. So as you heard, there was a lack of resources that was expressed by our participants, and they wish they had more information. So they would make some educated judgments based on the education or the opportunity to learn more about their prenatal experiences or their birthing experiences as a whole. We noted that there was culturally responsive training for medical personnel that was needed. We understood that the programs being centered on Black women's experiences and medical needs. So we also wanted to share that intervention that we propose here, also solidarity with Black women. So all of these things came as a result of us listening, learning and understanding, and then wanting to make sure that we made note of these things so that we can move forward and give some opportunities for some interventions that we could possibly move into action in our community.
Thanks, Christina. As we near the end of our presentation, we wanted to share a couple of or kind of supporting research that we did and some of the work in creating some of those materials about resources and about Black women's pregnancy and birth issues. We did develop this Black maternal health stats infographic that was circulated in local clinics. And this is something that would be very helpful for Black and Brown women to see in their healthcare offices, to know that their particular health needs are being addressed and that they are acknowledged. There was this kind of feeling in some of our focus group participants that we engaged in with them afterwards, stating that, you know, it seems like it's a trend, like black maternal health care is this national trend that everybody is supposedly thinking about, but then they would walk into their health or their doctor's offices and race was not talked about. Black women's health care needs were not acknowledged, and it was somehow these like kind of two different worlds that they felt that they were operating in. And create materials like this to help share statistics with Black women so that they can understand their own risks and their own pregnancy complications. And this is just obviously the beginning of what could be several infographic materials. And of course, the report that we have that's coming that can also supplement. I think the only thing I will say about this, because I know that we're going to send you the slides, is that you know, these are general statistics that exist nationally as well as around the world, and so this is just the tip of the iceberg in terms of the disparities experienced by Black families.
Thank you, Alex. And I do just go back to that slide just once again. I noticed that we there was some squinting and so that we could read the material. This material will be available to you, as was it available to read in bigger font at our health department. We place these periodicals, I'm sorry, this information right here in our waiting room. And pre-COVID, when a woman was waiting for her WIC appointment or any other appointment that she had at the health department, she was able to pick this up, or anyone, any caregiver would be able to pick this up and to read at the time that they were given in between appointments. So this is a great push and move on behalf of the health department to make this information available as soon as the data represented itself for our community as a need.
Thank you.
Yeah, thanks for that. Going on to the next slide though. This right here is a data report or a graph, an infographic that we used. One, it was used in an anti-poverty work group that Jill Collier just talked about. I'm sorry, Jill just talked about and gave you information about, and I'm sorry I messed up your last name, Jill, but obviously you're not Jill Collier. But this is the Healthy Communities Initiative data that came as a result of a grant that Kansas Health Foundation funded. And the data collected here was from 2019 and 2020. It was a collection of over 100 residents of Douglas County under the poverty level, who were living 200% under the poverty level, who were also receiving housing assistance. And the questions here were, what are the barriers to employment opportunities in Douglas County? A couple of the also came from self-identified people of color. So we were able to make an extensive reach, and an intentional reach to understand from these 100 participants who answered the questions, what do you find as your barrier to employment opportunities here? And as you read, there are two that stuck out the most, one being prejudice or racism, the other is lack of educational support and job match, and the third, following very closely behind, is the lack of transportation. So these are our communities' answers to questions that we collected data and place on this graph so that we can understand how to move forward in our anti-poverty work group and how we can make directional, intentional choices to address these inequities that our community is speaking that are representative in their lives.
Thanks. So we definitely wanted to include a slide, and when you have it's in your email inbox, you can actually click on the links here to go to these studies and articles. But we have an extensive resource list if you would like to read more, again, including that University of Virginia's work on pain management in Black patients. We also have an article about just general healthcare disparities across race. As well as the lack of correlation between socioeconomic status and actual health outcomes that is actually seen in the Black community. And then we also wanted to drive home a couple of narratives. I'll talk about Serena Williams, and maybe Christina, if you'll talk about Deja Stallings. But we wanted to talk about, we definitely wanted to share this article about Serena Williams. She was a very high profile Black maternal health case. She almost died in childbirth because she was not listened to by her medical professionals. And if anybody doesn't know who Serena Williams is, she's a very famous tennis player. She has probably one of the best health insurances that people could probably get. She's very body literate. She understands her body. She's experienced health issues before, and the health issue that she was experiencing during her or shortly after her birth was a pulmonary embolism, and she knew what was happening, and she was requesting medical follow-up and specific testing to help her with that issue. She was experiencing a lot of pain with this, and they did not listen to her until it was almost too late. And so that was a very high profile case that I think shook a lot of Black women because, you know, this is a Black woman who's very rich and very famous, very visible, has, you know, probably every inch of her body is insured. She is an excellent athlete. She's you know, like she has all of the things that the white medical complex has been telling Black women that if only they had, that they would have these excellent outcomes that white women typically have. And so she was a very important case, and I definitely advise looking into what happened with Serena.
And you mentioned, Alex, Deja Stallings' name. So I thought what would it be important to do would be to give an understanding of, yes, Serena Williams, a very fit, very well-known, very public profile Black woman who had experiences with birth, and her birthing experiences were pretty negative. Had she not advocated for herself, I think she would have had a very different outcome. But as we were talking about Deja Stallings, this is a local, or a Kansas Black woman who, during a arrest, or during the protests in Kansas City, she was handled very negatively and very forcefully by the police and by the law enforcement in Kansas City, Missouri. So it's not Kansas, but it's right there close to us. But it happened this year. So though we know and though we understand that these things don't happen close to happening and very close to our space, Deja Stallings was 9 months pregnant when she had a knee put into the back of her, into her back while she was pregnant, and she was detained by police officers. This is just an example of the maltreatment that comes with Black women experiencing being pregnant and not being protected. So there could be some argument, being that she was at a protest, being that she put herself in that space. I think the real point to understanding and to even talking about Deja Stallings is that these are Black women who are treated as though they are less than. And the mistreatment and the abuse of Black women and Black mothers is something that we want to make sure that we're taking note of.
Yes, thank you, Christina. I think the last thing about Deja's case was, I think she had a young child with her, or was that maybe another case that I'm remembering? There was a video going around this week where there was a Black woman being approached by a Black man, and she had her young children with her, and he was yelling at her.
Well, Deja Stallings was in Kansas City, Missouri during the protest. She was 9 months pregnant. So there could have been a child, an infant with her. However, the video depicts and is very graphic. It depicts the treatment of Deja, 9 months pregnant, laying on her stomach and being forced to lay on her stomach and pushed down at the hands of the police. Knowing that, you know, there were people around who were filming and saying that, and giving the police the indication that this is a woman who is in a position of powerlessness, and now you're putting her in position of even more powerlessness and possibly endangering her unborn child. The infant was born 2 weeks early and had an elevated heart rate. So that's just bringing it to some local information. I'm sorry, some recent information that is not so much local, but Kansas, Missouri, Kansas City, Missouri is not very far from us here
Yeah.
in Douglas County.
Yeah, no, thank you for clarifying, because there are many
Yeah.
examples of Black pregnant women and also Black elderly people, Black people living with disabilities. Just as a society, we are more comfortable mistreating Black patients and Black people in our community through law enforcement. And so that's definitely a trend. And going back to University of Virginia with the general belief of Black people feeling less pain.
Right.
But thank you, everybody, for listening to our presentation. We hope that you'll look into more information that we shared, and maybe even further beyond that. We definitely want to give thanks to our partners. Christina, I don't know if you want to take it away.
Sure, and please just kind of step in with some names if I forget them. But we worked with Erica Hilscar at LMH. We've worked with Jen Preston, who used to work for us here or at the health department, has since moved on to beautiful things that she's doing for the community. There was Tracy. Please remind me of her last name. Definitely don't want to. Tracy Dotson. Definitely don't want to leave her out. And Alex, could you give some of our partners' name that work at LMH?
Yeah, so I think Erica Hill was the predominant partner there, but we also worked with Dr. Lindley Holman, their gynecology services over there. She was very helpful for us in terms of, I think she had looked at some of our focus group questions, and she had looked at some of our research, and so she was very helpful talking to. And then we've also given a presentation to their equity team over there as well at LMH Health.
Right. And then also not to forget Sarah Hartzig and Vicki Collier Akers, who are the two people who helped giving it Kansas Department of Health Education, giving us the green light to work on this project here. So
Yeah.
big ups to them too as well. Like Alex said, we couldn't have done this work alone. It was definitely not just a two-person effort. It's a community effort. And we're hopeful that in sharing this information with you all today, this becomes a county effort as well.
Awesome. Well, definitely feel free to contact us. I can also put our email addresses directly in the chat so that it's easy to copy and paste if you like. We are so glad that to have your time today and this floor also to share out into the community.
Thank you, ladies. And before I open it up for questions from commission, I wanted to real quick just let the commission know, very soon you'll be hearing more about the community health plan and the anti-poverty work group and some new elements of the community health plan that we're very excited about. But just so you know, just another connection to the work that we're doing currently on the health plan. This may change slightly, but the overall objective for the anti-poverty work group is by 2023 to create policy, system, and environmental changes that results in an environment in which the percentage of BIPOC, Black, Indigenous, people of color, children live in poverty does not increase. That's our overall objective right now. And so again, I think how do we inform those environmental changes and those systems and those policies? And I think the information that Alex and Chris present, it's life or death for folks in our community. And this brings a little more context to the work we're doing. It brings more context to statistics that we're familiar with at our organization, like the disproportionate numbers of Black people that are have been incarcerated in the Douglas County Jail. And I know that's an issue that's important to all of us. And again, I appreciate you letting Alex and Christina present this today.
Thank you, Jill, and thank you, Alex and Christina, for your presentation. I want to open it up to commissioners, see if they have any questions for you.
I was just thinking through the whole presentation, especially in the presentation, how that information can be relayed to our actual local provider, to our the folks who are giving the care directly to pregnant women, or pre and postpartum, and kind of our huge pediatrics groups and our Heartland Health. And I mean that's a large population that involves a lot of folks in the hospitals, practice, women's practice. I guess I'm interested in knowing how this goes beyond kind of the public health arena to actually reach those folks who are at the bedside giving care or meeting women in their appointments.
That's a great question, Nancy. And I was going to kind of pass it off to Alex because she had spoken half of our presentation. We are making sure that we are presenting data anywhere that people want to hear it, but absolutely getting it to the people who are accountable and play a big role in our health as it serves us. I think we only have one hospital here, so it'd be great that our one hospital has this information and can do something with it. So Alex, I'm sorry, go ahead and speak to the question.
No, great context. There's a lot of methods for introducing material to healthcare workforces through the use of resource sheets, trainings, panels, and things like that. It would be great to see something like this maybe not be voluntary. Maybe this could be something, because I know that generally there's equity training and equity understandings, especially here in Lawrence within Douglas County. But it would be great. Christina have had significant outreach to Uzazi Village and some of the alternative community leaders within that. And so I think empowering these other options outside of LMH Health would be great, and creating those connections too with LMH Health. And again, that's where being on the inside with their equity team and with Dr. Lindley Holman is going to be really, really powerful. The information gets out there because our folks just the doctors that they were experiencing discrimination or othering feelings from, but also the nurses and the front of house staff. So like people working in the offices. And in my experiences across public health sector is that typically these equity trainings are geared towards medical professionals, but not always their front office, taking those people to and making sure that they're involved as well, because patients have a lot of interfacing with those people. Really great question. We are all about action, like making this action, which is great. Theory is really great. I live there, but it's really great to also make the information accessible. I think across different audiences, we want to make sure that the community members can understand their research as well.
I think it'd also be really interesting to study what our own, the one and only medical school in Kansas, what's KU Medical Center, how are we teaching our new doctors and new nurses and all those folks? Is there kind of that racial equity training or anything like that, any intentional work going on in the not very far from our doorstep? So might be extra good information.
Yeah, there's significant medical activist history in Kansas City, and also with the University of Kansas Medical School. Up until a certain point, Black students could not progress further in the program beyond a certain point for the first 2 to 3 years, but they couldn't actually achieve their degree here. And so we have that kind of historical disparity in our local researchers and medical workforce, especially as tied to Kansas City, because that's where KU Med is kind of stationed at.
Yeah, my question was sort of similar to that, and I was happy to hear you say, Alex, that sometimes we need to require people to hear it, not just so to push beyond those who want to hear it, as Christina said, and get into those who have to hear it if we want to make progress on the disparities that you illustrated. And I was sort of interested in sort of a similar question to Nancy's. Some of the strategies you suggested, like improved office protocols and culturally responsive training, have you approached, how have medical professionals responded when you have shared this information with them?
Yes, we've also done a lot of research into what culturally responsive care looks like for different racial and ethnic groups, and we have a lot of information about that. The main response that I get from people is that there's not enough time, that their jobs are very demanding, and especially right now during COVID-19, that engaging in any excess training is just kind of out of the question. But even before that, people would often refer to their annual equity training if they did have one that was required, or maybe one that was required with their onboarding into that job position. They would often refer to those as being, well, I learned that already. Like I got that, like I checked off that box, which ignores the fact that research is constantly coming out. It ignores the fact that this is something that needs to be maintained. It's not something that you learned once years ago, or even within that same year, and that you're going to be accurately applying across the board. And of course, it's important to hear from different people and different resources. Having 2 facilitators come in one time doesn't give you an accurate understanding of everything about health inequities and what you can do as a result of them. So this is just I could go on and on about that, but yeah, there's definitely mixed response. Our response at LMH Health has been very, very positive, though, in terms at least of the equity and the leadership over there. Can't really speak at the doctor and personnel level, but it seems like that they're very interested in working with us.
Yeah, it would be great if all of our biases were conscious. So it sort of assumes that once you hear about it, you're conscious of bias from then on out. So I appreciate that. My other question is, I want to hear more about, and Jill, it sounds like you're coming back to the county commission with the CHIP and some policies. Are there policies, have you talked about the policies that the county commission might be able to enact that might help address this?
We have not gotten there yet. I think that the work that we will share with you in the new year and share with the community in the new year on the anti-poverty work group are largely, and there's some intersectional strategies as well that go into other parts of the chip, the other planks of the chip. But it's 3 focus areas, jobs and employment, and childcare, and decriminalization of poverty. All real meaty issues. And what I can speak to myself is I was a co-facilitator with Hugh Carter of the decriminalization of poverty. And if you remember what the focus, what the key objective of the anti-poverty work group, it really does focus on BIPOC community members. And to be consistent with that, the strategies that are recommended in the decriminalization of poverty are also focused on BIPOC communities. And so it's not really, we're not looking at policies yet, but we're encouraging organizations and existing systems and groups like CJCC and elected officials like district attorney and other agencies of influence, including our own, to make space for the shared learning and reflection and data collection and data sharing that needs to happen to better understand how race is playing out and impacting BIPOC communities, and making sure we're so it's more understanding what's happening today and making space for what's possible. That's largely what's in our strategies. We don't feel like we are anywhere close to just yet recommending any key policy changes just yet. But I don't think it's going to take us much time to have some policy recommendations on things that are fairly low hanging and that there other communities have done. And one specific area I can talk to are around driver's license revocations and fines and fees. Those are things that we can on a local level with some intention and some direction from the key leadership of organizations like ours and the others that say this matters. We want to understand it, and we want to understand what alternatives exist, because what we know, I want to say we conclusively know, but we have a hunch that there is a disproportionate impact on BIPOC communities for fines and fees and driver's license revocations. But we need that data to show us that. And then we need to have meaningful conversations. But those are those environmental factors, those, outside prejudicial factors that when you looked at that anti-poverty survey slide that Christina presented, there's all these other factors that are contributing at a community level and a systemic level that are contributing to maternal and child health. Beyond the medical providers, those are equally important, but what we can influence, I do think that we're going to at least chart a course to get there, but we need to make space to make sure that we're including the right folks at the table and that we're holding the right folks accountable as well.
I think the only thing that I would add to that, Jill, is the community resource navigation could have a lot of positive implications for Black maternal and child health. But you really covered it. There's so many of the cross-cutting strategies that obviously will apply a little bit.
Definitely. I wanted to just add to that. I don't want to cut off anyone's questions. I know we're at 4:58. But we are also speaking about lived experiences and incorporating the people who have had the experiences, who can tell us what works, what won't work, what are the barriers to this resource that we're working so hard to create, because if it doesn't make sense, then it's going to be something that we're going to invest in that won't really go into helping to support to reduce these inequities, right? So lived experiences, collecting data from folks continually to ask the question, to come to our engaged opportunities. One experience I can just share today, only because it makes sense to, it's kind of serendipitous that I'm here today. It was 22 years ago that I gave birth to my son. My son's 22 today. And his birthing experiences for me, or my birthing experience with him, was the most negative out of my 5 children. And it was because some of the things that we've heard tonight coming from other women saying that I wasn't listened to, I wasn't told that these options were available to me, the resources were not specific to my needs, and they didn't make sense for me to engage with this program because I didn't have enough money to even get to that program. And so, and because there's this lack of education. In my experience, it was the pain that I was perceived to be painful for me was told, and I was told otherwise by the nurses. And so as a result of that, he had to stay into the ICU for 2 days. I couldn't bring him home with me, but he's here and he's 22, and I've, had a lot of experience with children, and I've had a lot of experience with my own children. I've also had a lot of negative birthing experiences. And it was because of the doctor-provider care biases and lack of education for me, understanding what my options were. It was because maybe there wasn't a doctor of color that would have been able to see and understand and note that this is what we're talking about right here with this one particular patient. So we talked a little bit about racial concordance and how having a person of color working in professional leadership there at any place makes it a little bit easier for a person of color to be treated fairly. And that's not to assume that that's going to always happen, but the chances of it happening are far more than if it wasn't.
Well, Christina, thank you for sharing your lived experience with us. I mean, only by hearing those stories and understanding can we try to make progress on this and find strategies to address them. So I really appreciate you both coming today. And Jill, thanks for your work in this group. And I know the county plays a role as we figure out what that role is. And I look forward to that. Commissioners, any other questions? We sort of are reaching traditionally our end time for our meetings. All right, well, thank you both very much. We really appreciate the work that you've done and your whole team. So with that, we will adjourn until our 5:30 business meeting.
Thank you for having us. Have a
Thank
good
you.
evening.
Thank you.